your immediate management plan, right? So it could mean that if the patient have that, you are concerning for life-threatening conditions. It can help you decide what is the disposition for the patient. For those who are not familiar with that word, disposition is the term we use in the US for where the patient's gonna go from the current setting that you are at. So it can be that the patient presents to the ED, and then the disposition for patient can be either admitted to the hospital or discharged from the emergency room. It can also mean that, like, so let's say you decided the patient is gonna be admitted. Which level of acuity does the patient need? Is it just a regular hospital ward, or is the patient need intensive care unit? And it's also gonna help you decide how quickly you have to start treating the underlying problem, or you can actually watch and wait and see how things progress. So that's how at least I think about when we talk about red flags. And it very much depends on the presenting symptoms and the differential diagnosis, right? This is the part where your medical judgment gonna be heavily needed, right? You need to know what you worry about to actually start asking the right questions. All right, next please. Yep. And the last thing I say is, like, trust the parents' instinct. So, like, no one knows the child better than the parents. They are with the child every single day. They see the child progress through when they're healthy, through the illness episode. So usually after I ask the basic questions, the first thing I usually ask them is, why did you decide to seek care today? Because most of the time patients don't go to the hospital on the very first sign of symptoms, right? They usually probably have fever for a day or two, having a little bit of a running nose and a cough. But there's something that must have happened that drove them to decide to go to the hospital on that specific day. And that usually the thing that the parents are concerned about, and that usually might help you clue into what is important to ask. So the sample question I usually ask is, like, why did you decide to seek care today, or what changes caused you to come to the hospital today? Next slide, please. All right. So as I say, red flags is dependent on your differential diagnosis. But in pediatric, especially with a child who has fever, there's a few things that we call do not miss. So, like, this is the conditions that you should never miss in when you see a patient with fever. The first four I listed here: dehydration, respiratory distress or failure, any impending cardiovascular collapse, and any CNS involvement. Those four only need to be addressed in any patient with fever. You need to making sure that none of those happen. Kawasaki disease and the rashes is a little bit more advanced. I just included here so that you guys hear about it, you guys get some vocabulary out of it, but that's not gonna be the main practice point for you guys today. The first four would be the main practice for us today. Next slide, please. All right, so let's talk about dehydrations. This, for me, is the most important thing to rule out whenever I have a child with fever, and that's why it gets included into my mnemonic when I ask history for fever as my triage questions, right? Drinking, eating. Because when the child is dehydrated, it generally shut down the rest of the functions, and it causes a lot of the other problem to happen. So if you can help support the child with that, this usually can save you a lot of trouble later on. So the usual, the sign and symptoms are decreased intake. If the patient have any increased loss, that will increase the risk for having dehydrations. Like, so if you get a history with persistent vomiting or diarrhea, if the patient have had fever for a prolonged period of time, if the patient have any kind of burn, that can cause increase in sensible loss, that would cause you to be a little bit more concerned about dehydrations. And obviously decreased output. So if they don't have enough intake, they will not have enough output. Next slide, please. All right, so this is the couple questions that I usually ask. So for a bigger kid, you can ask like, how has your kid been drinking today? How is his or her appetite? Tell me what he's or her able to eat during in the past 12 hours. I usually give them a specific amount of time rather than just ask like how it's been eating, because sometimes it's hard for the parent to remember. So I just like think back, what did he eat for dinner? What did he eat for breakfast? Like I give them a very specific timeline, and it usually make it a little bit easier for you to kind of judge the amount as well. Next slide. Oh, go back. Thank you. Yep. And then for the decreased output for younger children who's not toilet trained yet, the question generally, how many wet diapers did your kid have today? When was the last time he or she had a full wet diapers? If a baby does not have wet diapers for more than 8 hours, that is a concerning sign for dehydration. So those would be the important question to ask if you have any kind of history concerning for higher risk of dehydration. Next slide. All right, and then the next conditions that you need to making sure you rule out is respiratory distress. So as we discussed last week, the most common cause of fever in children is generally a viral infections. Sorry, I need to run.
Okay, it's time for you to step in.
Okay, so for the young children, there's a couple of signs that you want to ask if the patient is having a hard time breathing. So usually we want to ask for any increased breathing rates, any abnormal sounds like grunting. Sarah, you want to take up? I just run through the list of the respiratory distress.
Okay, perfect. Thank you. Sorry, I don't really know what happened. But thank you for taking over. So respiratory distress sign is generally like for bigger kids, you see like tachypnea, you see grunting, you see retraction. Like for younger kid, I mean, you see tachypnea, so faster breathing. Compared to the normal age group, right? So every age group have a different normal respiratory rate. So you have to kind of remember what is the normal respiratory rate for each group. And then if it's faster than that, it's usually a sign of respiratory distress. Grunting is the noise that the child makes when they are trying to keep their lungs open. If there's a video in the next couple of slides that has the grunting sound that we can watch as well. Retraction, so when you start seeing babies showing ribs whenever they breathe, is another sign. Nasal flaring, head bobbing, and belly or seesaw breathing is one of the common signs for respiratory distress and failure in children. So this is usually the question I ask them. So did you try work hard to breathe? Did you feel like he or she breathes faster than usual? Did you notice his or her ribs when he or she's breathing? Next slide. But again, this is where you really want to lay eye on the child. So physical exam is crucial because it's really hard for the parents to diagnose respiratory distress. So usually when I get a history where I started to hear a lot of like, I think my child is working harder to breathe, he start making like weird noises at home. So if the patient is calling on the phone, I would ask them to come to the clinic or come to the emergency room if it's after hours for the child to be evaluated. Next slide. All right. If you click onto the square, it will go. It takes a little bit of time. The video is a little bit long. I think it's about 10 minutes long. So you guys have the slides on the Facebook group. So if you guys want to go onto the Facebook group, so you should be able to get access to the link to watch the video. I highly recommend it for those who have especially interaction with children to watch this video. We can move on to the next slide here.
Get stuck. Huh?
Yeah, I think, do you want to stop share and try again? I think that might help.
Okay.
Stop share and then share it and then start at the next slide.
Okay, here we go.
All right. See if we can move on. Perfect. All right. So for older children, it's a little bit easier, right? Because you can actually talk to the jar and kind of get a little bit of a better sense. So usually older children will describe that as like, I seem like I couldn't really catch my breath. They can have some chest tightness. They can have shortness of breath. A lot of time they will describe it as chest pain. It's just because they couldn't really distinguish between the tightness and the actual pain. So they usually call this chest pain. And a very useful thing to have is that if you start having a child who cannot really speak in full sentences, that is usually a sign for me that there is something wrong with their breathing. And then wheezing and stridor are abnormal breathing sounds that a child can make that can signify some issue with the breathing process. So the common questions: did you find it hard to breathe? Did you have shortness of breath? Is it difficult for you to catch your breath? Is the common questions we would ask. All right, the third condition that you need to making sure you rule out is impending cardiovascular collapse or simply shock, right? So I'm not going to go into the different kind of shock, but in general, you will have some level of impaired perfusions. So you might see some paleness, especially in the hand and feet, cold hand and feet. You start seeing some skin modeling. It's I think in Vietnam it called like yeah, nổi bong. And then sometimes in children, like the first sign of heart failure, especially in neonate, are profusely sweating. And then again, if your blood pressure is really low, you start having altered mental status. So this is what I would ask for those. But again, when you worry about these, they probably need to be seen by a physician, and you need to do a careful physical exam on them. Next slide. All right. And then the last one is any kind of central nervous system involvement. So there's a lot of infections that can happen in children, and usually most of the time the body will take care of it. The common things, the one area where the body tend to have issue with is whenever the infections get into the central nervous system, because usually even just the immune reaction to try to fight the infections usually cause issues to the brain and then the nerve tissues as well. And that's why you need to kind of keep an eye out for those signs, because the patient will need more support and most likely will need to be admitted. So any kind of altered mental status, so excessive tiredness, very fussy, inconsolable, lethargy, somnolent, and then altered sensations, so numbness and tingling is important, because sometimes you can have transverse myelitis, right? So inflammations of the spinal cord that can start causing some sensation issues. So it's important to rule out. Any kind of loss of functions or weakness. Sometimes it can hard to ask those questions with children. So sometimes I would ask them, like, have you seen, have your kids seems to be a little bit more clumsy lately? Have they fell a lot more compared to usual, or have they been like dropping things a lot more compared to the usual? Because if you start having like muscle weakness in the hand and feet, you start like falling a lot more. You don't have the grip strength to hold on to things. Abnormal movement is to assess for any kind of seizure activity. Onto balance is also an important one. And then vision changes and loss of bowel and bladder control. So usually this is what I would ask them if about bowel and bladder control. So I would ask them, especially in children who already been toilet trained for like a good few months, if they start to all of a sudden having more accidents, like they start wetting their pants or soiling their pants, it's usually a concerning sign. So that would be the list that I kind of try to screen for those symptoms. Next slide. All right, so we kind of cover the 4 most important conditions that you need to rule out. Now we're gonna talk a little bit about a more pediatric specific condition. So this is a little bit medicine heavy, but I think it's a good kind of topic to kind of hear at least once so you get familiar with some of the terms. So Kawasaki disease is a very pediatric specific conditions. It's immune mediated systemic inflammations. So it's not caused by an infection. It actually is an overreactions of the immune system. It can lead to coronary aneurysm, so dilatations of the coronary arteries, and that can cause heart attack, and the baby can go into heart failure. So the mnemonic that we use in the United States for Kawasaki disease is crash and burn. So crash is stand for C. conjunctivitis, so they will have bilateral red eyes. Because it's a systemic condition, it will always gonna be bilateral. They have rash, they have adenoma, which is the term for swollen lymph nodes, and the most typical is cervical lymph node. S stands for strawberry tongue, H stands for hand and feet redness and swelling. And then burn is just for fever more than 5 days in a row. So usually this is where the onset become important questions. Because if I start hearing of a baby who have been having fever for 5 days, this is where I start asking for those specific symptoms, because that is the one thing I need to rule out. I need to making sure that they do not have symptom concerning for Kawasaki disease. Next slide. All right, so this is just a picture of presentations of like the information that just mentioned. So it's for anyone who's out there that a little bit more visual driven, this will help. And then the video down there is the review video for the topic if you guys are interested. Next slide. All right, and then lastly, we were talking about rashes. So pediatric rash is very, very common. You will hear a lot about rashes. There's majority of them are benign, but there's a few of them that are very deadly, and generally we try to recognize them as soon as we can and try to manage them as soon as we can. So again, this is a little bit medical heavy. So for those of you who's not in medicine or not really taking care of pediatric, you can probably ignore these parts. So the first one is Stevens-Johnson syndrome and toxic epidermal necrolysis, or TEN. So this is a drug reactions. It causes very intense redness, rapidly spreading, and usually involves some mucosal involvement. So the eye, the mouth. It usually associated with new drugs, most commonly antibiotics or seizure medication, anti-epileptics. So usually when I have a rash who's that looks a little concerning to me, this is the question I always make sure I ask is that is your child on any new medications recently? Because that might drive me toward ruling out these kind of conditions. The next one is necrotizing. Go back. Thank you. Next one is necrotizing fasciitis. So I think you guys are probably familiar with this. This got onto the internet quite a bit in the past couple of months. So it's a flesh-eating disease is what the common term is known as bacterial infections of the fascia of the muscle. So it's allow a very easy spreading land for the bacteria, and it causes devastating muscle injury and cause severe shock. So usually this is what you try to recognize. So making sure you rule out any kind of injury prior to the presence of the rash is important. Next one is meningococcemia. So this is a medical term for bacterial infections caused by bacteria called Neisseria meningitidis. This causes commonly meningitis in older children, but if it gets into the bloodstream, it can cause devastated and rapidly deadly disease, and that's why it's very important to recognize them early. The typical like clinical vignette for these conditions is you have a kid with fever, symptoms of meningitis, and started to have purpuric rash. Purpuric rash is the rash where when you press on it, it doesn't go away. Then last one is toxic shock syndrome. This is inflammations in response to staphylococcal infections. The most commonly associated is tampon use. I think it's gonna be a little less in Vietnam, since I think the vast majority of population in Vietnam use pad. But in the United States, they seem to favor tampon, and that can cause issue if left in there for too long. Next click, please. So this is the purpura rash on top. That's what it looked like. And then for the toxic shock syndrome, I usually be very straightforward with them, especially when you deal with teenager. You want to be as straightforward as you can. So I usually ask them, like, do you use pads or tampons for your periods? And how often do you change your pad or your tampon? Because sometimes if they left it in there for days, that will be a breeding ground for bacteria. Next slide. All right. So we talk about all of the red flags. So let's say you're recognizing now that there's a bunch of red flags that you are concerning about. And the parents probably will notice that as well, right? Because you start asking about things that you usually don't think about. So they're gonna start asking you. And it's also a helpful tool to explain to patients why you do the thing that you want to do, right? So the way I like to use to explain to patients is the term "I'm concerned." So that kind of telling me that there are a few things that make me feel uncomfortable, and it's also kind of express my like that I'm care about the patient health. So that is the term I use a lot. So I usually say like, I am concerned that your child has dehydrations, and this is why. And why is that important, and what I want to do about it. So that's what we're gonna try to practice today. And then the next part is to explain to patients what they need to look out for, and that's another important use for red flags. So a lot of times you will have patients who show up in the emergency room with fever. I would say 90% of the time you will send them home because you think they have a viral infection. But you will never be 100% sure that they just have viral infections, right? They can have complications from that. And your role is to making sure to educate the patients, the parents, on how to recognize when they need to come back and seek help. And so that is where you start talking about these red flags. So if I have a kid who's just having a viral infections, but I'm concerned that this kid might later on develop like, let's say, meningitis or dehydrations, I would say, I think your kid have right now just a viral infections. However, I cannot rule out so and so and so. So please return to the emergency room, or please return to clinic if you have these following symptoms. So that is where you can talk, like if your child have no wet diapers for more than 8 hours, if they have persistent vomiting or diarrhea, etc., etc. So this is where the red flags can be useful just to help to guide, to educate the patient on when to come back. So those are the two useful things that you can use the red flags for. Next slide. All right. So kind of just to try to put the two, everything together. So we talked about a lot of different ways to approach pediatric history, but this is the framework that I use to get history. This is a very comprehensive history, and I acknowledge that depending on where your setting is and how much time you have, you might need to truncate these a little bit and pick what's more important to get. But let's say you have time to get a full history. This is what I usually try to achieve. So the first thing is the chief complaint. For me, those mean why the patient is here, like cough, fever, whatever. The next part is the history of present illness. So this is usually the information that happened in the past few days that's related to the current illness episode. So I don't really care about what happened to them 10 years ago. It's what happened in the past couple of days, like where the fevers, like when the fever started around that time, what happened during that period. So this is the part where the patient will tell a lot of the story, and your job is to sit back and kind of listen. And then this is my first triage questions: why patients seek care today? So usually it will tell them what concerned them the most. And so that allow you to kind of recognizing some red flags, and as well as to help you to target your explanations and counseling toward the concern that the parents have. And then the next part is the history. So that for pediatric include birth history, medical history, surgical history, immunization status, and social history. So this is a chance for you to get to know your patient as a whole, right? Your patient just did not really just exist for 10 days. They had been on this earth for a while. Can we go back, please? Thank you. So it's important for you to kind of get what have happened to them. And this is usually contribute to where you get the information on risk factors and stuff. And then the last part is the review of system, where you kind of fill in the blank, like you have a framework of a story, but there's still a lot of hole that you that couldn't really help you make up your mind. So the review of system is where you kind of go head to toe and start to fill those blanks and screen for those red flags that you worry about. So this is kind of how I would approach a general history. All right, so I think that's all I have. Let's do some practice.
Okay, terrific. Good one, Sarah. Let me share my screen. Just a couple of announcements today. So today, the breakout rooms, you'll see that they're numbered 1 through 10, and then if you needed extra space, then they go after that.